Hello and welcome to eviCore Healthcare's educational webinar series. Today's topic is Radiation Oncology 101. During the next 45 minutes, you will learn about different radiation oncology treatment techniques and when they are used. There will also be a brief overview of the history of radiation oncology, as well as what is in store for the future. My name is Margaret Rausa, and I lead Oncology Strategy and Growth for eviCore. eviCore is a company that empowers the improvement of care by connecting patients, providers, and health plans with intelligent, evidence-based solutions to enable better outcomes. Throughout 2022, eviCore will continue to host free educational webinars that include guest speakers as well as eviCore subject matter experts to discuss today's most pressing healthcare topics. Please stay tuned for our future webinars, and we do really hope you will attend. And now, it is my honor to introduce you to Dr. Raj Singla. Dr. Singla is eviCore's Chief of Radiation Oncology, and he oversees all of the major clinical aspects of eviCore's radiation oncology service. Prior to joining the company in 2014, Dr. Singla practiced as a radiation oncologist with a variety of healthcare organizations over 10 years. Dr. Singla received his MD degree from Northeast Ohio Medical University, and he is currently a member of the American Society for Radiation Oncology. Before we begin, just a quick reminder to everyone, please submit your questions using the question option within WebEx. This presentation will be recorded, and it will be available on demand located on the Insights page at evicore.com. Now, take it away, Dr. Singla.
Great, thank you, Maddie. Thank you, everybody, for joining today. I thought this would be a great topic to present. Radiation is oftentimes an enigma for most people, and our goal today is really to try to introduce you to some of the topics and verbiage and various types of radiation that we are employing, that physicians are employing on a daily basis. So with that, we'll begin with just a brief introduction of what radiation is. Radiation is essentially packets of energy along the electromagnetic spectrum. The difference being that radiation is a very high energy wavelength here, as you see, and this high energy results in damage to DNA. So you're probably familiar with this and wanted to just reiterate that how radiation is working to damage the cell's DNA, the cancerous cell's DNA, and as well as the normal cell's DNA. The advantage that we see in cancer treatment with radiation is that the cancerous cells are not able to repair this damage, whereas our normal cells are. And this difference is what allows us to really use the radiation to remove, destroy, ablate cancerous cells, while the normal cells repair the damage and are able to recover in the vast majority of cases. You'll see here a list of various types of radiation. You're probably very familiar with the first couple of bullets. Photons is a general term for radiation, and that encompasses things like 3D conformal radiation, IMRT, SBRT, or SRS. And then again, you're probably very familiar with proton beam therapy, and there's different types of protons, but essentially that's a sort of a newer approach to treatment with radiation. And then there's a handful of other types of radiation that is utilized. We really don't see neutron beam anymore. Just for context, carbon ion therapy is going to potentially make its way to the U.S. for the first time in a couple of years. Mayo Clinic is looking to have one built in Florida in 2024, 2025. Brachytherapy is another type of radiation. This is essentially internal radiation, and that has a different, there are a couple of different ways of delivering radiation using brachytherapy. And lastly, radiopharmaceuticals. This is going to be an area that's going to be growing in the future, and we'll talk a little bit more about the lutetium-177 and PSMA in a little bit. But this just highlights all the various types of radiation that's often seen. For those that are not aware, this is a good example of what a linear accelerator looks like. This is essentially a machine that spits out the radiation to a patient, and this is another representation of how that actually works, where what you see is the beam of radiation that's coming out of the head of that unit and aimed at the patient who would otherwise be laying on that table. But what we can do is modify that beam, as you see here, to mimic the shape of that tumor. And this is how we are able to really be more conformal when it comes to delivering radiation to patients and to those tumors. Okay. Let me briefly touch on the various types of photon radiation. Again, for those that are working in sort of with radiation cases, you'll oftentimes get these type of cases coming to you, 3D, IMRT, et cetera. And so we'll just sort of touch on that. But before I do, I think it's important to understand history and historically what we used to do. It's really fascinating, and this is an example of, say, prostate cancer. This is before really the advent of using CT scans in the field of radiation oncology. We used to use X-rays, and this is an example of a pelvic X-ray where we were trying to treat a patient's prostate and the pelvic lymph nodes. And, you know, I think you can appreciate that when it comes to X-rays, you're not able to visualize the prostate at all. And so we did a lot of things at that time to try to determine the location of the prostate. We would inject dye into the bladder, for example. We'd even put dye into the urethra, and this gives you a good sense of where the prostate was. And what we would ultimately do is we might just draw sort of a circle or draw a shape close to the prostate that mimics the shape and do our best to identify where the prostate was. And this is how we did things, you know, before the advent of CTs. But with CT scanning introduced in radiation, we obviously were able to delineate these tumors, these organs very well, and this is a good representation of that. So what you see in purple is the prostate that you can clearly see on a CAT scan. And you can also see the various organs that we're trying to minimize radiation to, the hip, the bladder, and the rectum. And so what we do is we are able to reconstruct those CT scans into very similar images as I just showed you, but instead of sort of using dye in the bladder and other measures to determine where a prostate is, we know exactly because we were able to outline that on the CT scan. And essentially with 3D conformal, then we are able to design beams that conform to the actual tumor or to the organ in this case, while minimizing dose to the surrounding organs. And this is a representation of what that might look like. And so what you see in the middle, in the red, is really the full dose of radiation that we're attempting to deliver. And when we're able to use multiple beams emanating from the sides or from the front and from the back, when you use multiple beams, you're able to really conform the radiation very well to the tumor. And this is really where the term 3D conformal radiation comes from. And this is really the bread and butter of what we do in radiation. It works very well and is really sort of the base case for radiation delivery. 3D sort of evolved, or at least IMRT is an evolution of 3D, if you will, where we're relying a little bit more on computer and sophisticated planning to sort of tell the dosimetrist that's planning this radiation sort of the ideal beams or really beamlets that should be used to deliver the radiation to the target organ. So whereas in the 3D conformal, we've determined what beam and beam angles to use, and we've designed the fields or the blocks to outline or mimic the shape of the tumor. With IMRT, it's a little bit different, where the beams are still determined by the physician or the dosimetrist, but the shape of that beam and the intensity of that beam, the amount of radiation going through each of those varying shapes, differ. And that is all determined by this computer system to really bring the ideal number of beams and intensity to the target organ. And what is the point of that? And this is sort of a rough sketch that I drew up to kind of give you an idea of what that allows, what IMRT allows to happen. And that's really becoming more conformal. So if you imagine, as an extreme example, somebody who had a tumor with the shape of a letter H, 3D conformal, when you typically would use it, would generate sort of a pattern of radiation that mimics this square or rectangle here, so that anything inside of the green line gets the full amount of radiation. So you can see in this case, the tumor would get the full amount of radiation. And that's our goal. And that's what we've done for many years. However, IMRT can take it a step further, where it can become a little more conformal. And so this is another example of the same tumor, but I want to highlight that you imagine that there were structures that you wanted to try to minimize radiation to. And those are labeled A and B. And you can see that depending on the circumstances, the IMRT can certainly spare certain tumors or certain structures. So for example, if you had a normal organ or normal structure that was in this location, you can see that IMRT does a better job of conforming or carving around that. But you may have other structures that are just so close to the tumor that IMRT is not able to really spare that, or at least spare it to the full extent. And so I think the important thing is that we oftentimes look at this and might argue, well, IMRT should always be better. It's more conformal and it's always, got a better chance of sparing things. And I think if you left it at this view, you might say, sure, that makes sense. But some of that really depends on what the structures A and B are, and what are the tolerances of A and B. And those get into nuances that are really beyond the scope right now of this discussion. But I wanted to at least give you an idea of what IMRT's goal is. And so this is another example of in this case, prostate cancer, where the rectum, which, as you know, sits right up against the prostate posteriorly. With 3D conformal, you sort of see the first picture I'd shown you, the green line, where you're able to mimic the shape of the prostate, but invariably you can't conform as well, and you can see that the full amount of radiation bisects the rectum. And, the rectum tolerance is such that, these patients tend to have, if you at least treat it this way, tend to have a little more risk of radiation proctitis. And then that's really where the IMRT shows its benefit, of where you can be a little more conformal, but then you can start to really carve that radiation around the rectum. And so prostate cancer is an example where IMRT is really a standard and is used. Now, again, you might say, well, why wouldn't we always use this? And there are certain drawbacks to IMRT. It's not that IMRT is the latest and greatest and therefore always considered the best approach. So what you see on the right-hand side are some of the things that we appreciate as the limitations of IMRT. Probably the most important is organ motion. In other words, we recognize that when you treat patients, sometimes the patient's they're not in the exact right position, or their tumor's moving. And so you can understand that if you are more conformal, you're more tight around the tumor, you have less margin for error. If the patient's just off position enough, you might actually miss the tumor. And so it's really critical when you are using IMRT that the immobilization is solid, and you're using image guidance. So image guidance is something that is a measure where you would take CAT scans or X-rays, high quality X-rays before each treatment, and really make sure that the patient is exactly where they need to be, and sometimes even the tumor is exactly where it needs to be. A few other limitations in terms of radiation that get really a little bit more into the physics of it, but I think another important thing is the risk of a second cancer. Now, this hasn't been validated, with patients in some sort of randomized trial, but Eric Hall, who's sort of a pioneer in radiobiology, has published a number of different papers highlighting the various risks of IMRT, and some of that has, including increased scatter and total body dose, when taken together with some of the data from Japanese survivors of that bomb, has shown that there is indeed a risk of increased malignancy, a doubling of risk of a secondary cancer using IMRT. The risk is small at 10 years, but nonetheless, there is a risk. And so I think it's really important that as we look at 3D or we look at IMRT, that we are considering the risks of IMRT, if you will, the cost of IMRT for sure, but the risks and whether it's really supported by evidence. Another risk, if you will, of IMRT is something called the integral dose. And so what you see on the left-hand side is the same 3D conformal image that I had shown you before, where you're using, in this case, 6 beams to treat the prostate. This is an example of IMRT, and IMRT really accomplishes its improved conformality by using more beams, generally speaking. The more beams that you can use, the more conformal you can get. And on the right-hand side is an extreme example of that, where you're basically using beams from every angle, 360 degrees around the patient. And I think what you can slowly start to appreciate is when you go from 3D to your typical IMRT to VMAT or rotational arc therapy, that you start to see that a lot more of the surrounding normal tissues, which didn't get any radiation, are now starting to get low doses of radiation. And in this extreme case, every tissue around the prostate is getting low doses of radiation. And that's a trade-off. There's a risk to giving even small amounts of radiation to pretty much everything around the tumor. And that integral dose is something that has been studied in a variety of different settings. This is one, as a representation in esophageal cancer, where you can imagine when you're trying to treat the esophagus, which is right in the middle of your chest, surrounded by your lungs. If you start to give more radiation, albeit low doses, to a greater amount of your lungs, what is that risk? And a couple of papers have shown that the risk is that you increase the chance of getting a pulmonary complication or pneumonitis, for example. So it's important to appreciate the risks of IMRT, including that integral dose. And in fact, IMRT is not something that you typically want to use in children in pediatric age, because they're growing and you're exposing a lot more of that growing tissue to these low doses of radiation, and these children are at risk for secondary malignancy. So there's certainly a role. It's just we have to be very cognizant of where it should be used and where it shouldn't be used. These are, again, more examples of where IMRT has been looked at and studied. This is in rectal cancer, where IMRT did not show a benefit to patients with rectal cancer. And again, when you look at NCCN, they sort of they've had this position for quite some time. So certainly there are reasons why we would use IMRT, but generally speaking, it's not really a de facto standard for various cancers. This is an Astro Choosing Wisely campaign that came out in 2013. And again, IMRT is not something that should be routinely used for patients with breast cancer. That's not to say that, these rectal cancers or esophageal or breast cancers don't warrant IMRT. Certainly, there may be situations that do. And that's really where the expertise of that person looking at that case comes in to really understand, is there something unique about that situation that warrants the need for that improved conformality, which then outweighs sort of the risks of IMRT. So what I've listed here are a few scenarios or diagnoses or situations where we would routinely think that IMRT is appropriate and outweighs those risks. I will say, we sometimes will also refer to NCCN guidelines. There was a recent publication that had come out here in the last month or so, and it was really interesting because what they had done was they looked at NCCN guidelines in total and found that only 10% of NCCN guidelines when referring to radiation were based on evidence. 90% were really based on opinion, expert opinion. And I think this really underlies the fact that it's important to really be aware of the evidence, such as I showed you just a couple of slides ago. Where does IMRT truly show a benefit versus the sort of the theory or the idea that IMRT is more conformal and therefore it automatically is better. So again, my goal is to kind of highlight just what 3D is, what IMRT is, what are some of the reasons we would use IMRT and why not. And so we'll briefly here now switch to stereotactic radiation. Again, another way of delivering radiation to tumors. So stereotactic radiation, there are really two types of stereotactic radiation, SRS and SBRT, terms that I'm sure you've heard of or seen here. And essentially what it boils down to is SRS or SBRT is really the same thing as what I've just been showing you, the same thing as 3D or IMRT. In fact, that's how they're planned. The difference is really that with each of the treatments, you're giving a much higher dose. So with 3D or IMRT, you're typically giving, relatively speaking, low doses of radiation on a daily basis, and you spread that out over 6 to 9 weeks, depending on the tumor type. With SBRT, you're giving double or sometimes even triple the amount of radiation, but because you're giving such high doses of radiation, you only do it for up to 5 treatments. And so, there are certain advantages I'm sure you can appreciate for only limiting a course of radiation to 5 treatments, but also you appreciate that you're getting much higher doses. And so there are certain requirements. Immobilization we talked about with IMRT, but you got to take it up a notch with stereotactic radiation. So this is just highlights some of the different terminology when it comes to stereotactic radiation. SRS is typically reserved for radiation when it's done within the brain and given 1 treatment, whereas fractionated stereotactic radiation is really something we use to describe regimens that are within the brain but done in 2 to 5 treatments. And then SBRT, which is also known as SABR, is given outside of the brain, and that can be 1 to 5 treatments. And, we're not going to touch on coding in this session. I certainly can answer questions at the end, but sometimes the confusion is, even though this is really not SBRT when you're treating the brain, the billing often is mimicking that of SBRT. So, little things just to be aware of. If you haven't seen or aren't familiar with some of these SRS, you might have heard of the term gamma knife. This is just a representation from the manufacturer. And this is a little bit of a different approach to using radiation, which is, you're using radioisotopes, in fact, all around the patient in 360 degrees. And depending on what you want to treat and how many lesions you want to treat, each of these may or may not open and deliver the radiation to the tumors as planned by the radiation oncologist. You're probably, again, familiar with the term cyberknife. This is another example of how to deliver stereotactic radiation or stereotactic body radiation. So again, just a variety of different ways of doing it. This hopefully gives you a little bit of a sense of the types of things that we're using SRS for and SBRT for. I think you can appreciate that essentially many tumors within the brain, malignant or benign, are oftentimes eligible for stereotactic radiation. And I think you will appreciate that because stereotactic is a very high dose. We talked about the immobilization, but then you can also appreciate that the conformality is even greater with stereotactic radiation, even more so than IMRT. And we're better to use a very, very highly conformal treatment than in the brain where you have a lot of critical structures. So I think that's something that you've probably seen and appreciate. SBRT is, again, used sort of routinely in a variety of situations. It really started out as a sort of a substitute for surgery. So for those patients with early stage lung cancer who were not medically operable, SBRT is actually allowed for patients to be treated very similarly to surgery and with similar outcomes. So it's a great option for patients who have early stage cancer and who are not operable. We're also using SBRT for a variety of other tumors, prostate cancer, pancreatic cancer. But one that you probably are starting to appreciate more is in the last bullet, oligometastatic disease. Again, we're not going to get into the nuances of oligometastatic disease, but briefly, oligometastatic disease is really a state where a patient is found to have really just started to metastasize. A patient might have been treated for their primary tumor, done well, potentially even cured from it, or at least looks like everything is under control, and then a year or two or longer, unfortunately develop a metastasis. And oligometastatic state is felt to be a state, sort of an intermediate state from when before the patient sort of develops widespread metastasis. And again, you may be familiar with some of the surgical literature and doing resections of the metastatic lesions in the lung or in the liver from various histologies like colorectal cancer. And again, it's the same principle where instead of surgically resecting these metastatic lesions, you can use SBRT to ablate them and really try to accomplish the same outcomes. And certainly there is a role for SBRT in this oligometastatic situation. I think this area is really continuing to evolve. The data's, there's some data on this, some of it's good, some of it's not so good. But what we're seeing is a continued expansion of SBRT use, not just in these true or what's called genuine oligometastatic sites or states, but situations that tend to mimic oligometastatic disease. Patients had widespread cancer and then might have had chemo and now just a few tumors are left. And that, I think you can appreciate that's different than a patient who's been out years from their cancer and now has one or two lesions and has never needed anything else in the past. And so, as this continues to evolve, as the data continues to come out, we'll certainly continue to evolve how SBRT is used in those various situations. Okay, with a few minutes left, we'll talk a little bit about protons. Again, we're not going to get into too much detail, but I thought it'd be important to just, highlight what proton beam therapy is. It tends to be a lightning rod in the field of radiation. And so, I think going back to your high school days. I mean, what you see is essentially an atom here, and the proton is the charged particle, and we have these cyclotrons that essentially generate these protons and at very high speeds, and is able to send these through to essentially these units where you can treat the patient. It's quite fascinating, and if you've never seen one, to be able to see one in person is really a tremendous visual to the eyes here. It's massive. The whole unit is terribly massive. It's quite a cost to maintain, and really the reason why protons are very expensive when it comes to reimbursement. The maintenance and costs are really terribly expensive. But why is proton beam thought to be really the sort of a lot of potential here? And again, this is more of a physics, radiation physics principle, but we'll show you on the next slides, how this pans out more clinically. But generally speaking, when it comes to a proton beam, which is in red, the way that proton beam works is it enters the patient and really does not much of anything. It sort of doesn't give off very much dose of radiation. It's sort of kind of quietly going through the patient. And then depending on the energy of the proton beam, at a very specified distance, it almost immediately gives off the full amount of radiation and then very quickly dies off. Whereas in X-rays or photons, it's a little bit different. It's basically, it enters the patient almost at 100% and then just slowly peters out and exits the patient on the other end of the tumor with a decent amount of radiation. And so you can see just from this principle, this Bragg peak, the thought is, well, wow, I mean, why wouldn't you want to use this for everything? And this is a representation, again, of protons for prostate cancer. So we talked already about 3D, and we talked a little more about IMRT and how you have to use multiple beams, and all of those multiple beams leads to this higher integral dose. You start to treat a lot more tissues around the tumor with lower doses of radiation. Well, protons, as we just showed you, tends to kind of come into the patient sort of quietly, doesn't give off much radiation, then at a certain distance, gives off most of its radiation, and then sort of exits the patient with very little radiation. And, I think if you just look at this, representation of prostate cancer, you might ask yourself again, shoot, why don't we just use protons for everything? And certainly that argument is out there. And I again go back to the evidence, and really where does it show, where do we find that protons in fact is actually better in delivering a higher cure or lower toxicity? It should be known that the amount of radiation going to the prostate is the same as it is with IMRT. So really the benefit of protons is not a higher cure rate. That's not the goal. Because again, the amount of radiation going to the tumor is the same. The goal of proton is really to reduce the dose around the tumor. And so the question, as we sort of talked about earlier on when you look at IMRT and 3D, is, what is the clinical significance of reducing the dose around here? And some might argue, well, you should just reduce it just empirically, because the less radiation, the better. And, I understand that. We also have to appreciate what does the evidence say about this reduction. And a good example is lung cancer, where a randomized trial was done at MD Anderson, and it showed that there was no benefit to protons over IMRT in treating lung cancer. So even though something sometimes looks better on paper, doesn't always translate into the clinic, doesn't always look better, or at least result in better outcomes. So, that's a very quick rundown of some of the things that we see in radiation, just to familiarize yourself with the various types of radiation. Certainly, I can take questions at the end, or if you had additional questions, we can always have a separate one-off meeting. But just for those that are not aware, this is something that's going to be FDA approved, here soon in the next few months, so we anticipate. And I think this is really fascinating. It's a radioisotope that is conjugated with PSMA, prostate-specific membrane antigen, and basically used for castration-resistant prostate cancer. Really a new sort of approach, targeted therapy, if you will, for these patients who have gone through already a variety of other treatments. And so something just again for you to be aware of, it is something that has been given sort of a preliminary breakthrough status from the FDA, but the formal approval is still pending. But once it is approved, I do envision that this is going to be used a fair amount for this cohort of patients. So just wanted for you guys to be aware. So I think when you really look at radiation, it's for those that are not in the field of oncology, let alone radiation oncology, it's tough. It's an area that you're not familiar with, and my goal is really just to kind of get you interested in, or at least get you to understand a little bit of radiation. And again, happy to take questions now, or we can always set up separate meetings if you wanted to go into any more depth. Well, thank you for your time. Appreciate it. Happy to take any questions.
Great. Well, thank you, Dr. Singla. It was a really informative and insightful presentation. We're going to move on to the Q&A portion of the webinar. There are a couple questions. The first one that came in is, can you talk about dose volume histograms and where they come into play?
Sure. Thank you. So yeah, this is something we certainly get a lot of questions around, dose volume histograms, DVHs, or comparison plans, as sometimes is conveyed. And basically, when you go back to the slide where we talked a little bit about IMRT versus 3D, this slide here, it's important to understand that, yes, so when you look at sort of the organ A, you might say, well, IMRT certainly is going to benefit that organ, and it is sparing it, but you have to understand that, every organ has a certain amount of tolerance to radiation. And so the DVH is really allowing us to understand, of these various different normal organs, how much of that organ is getting how much radiation. And so that's really a way that we in the clinic are able to ensure that we're not overdosing a certain organ, because we understand and we appreciate what the tolerances are of these organs. And so it very well may be that even though this is getting the full amount of radiation, whether you're doing 3D or IMRT, it may not matter because this organ has a very high tolerance to radiation, or it's not a critical organ. If structure A was your brainstem, then you certainly want to use IMRT to spare that because the brainstem has a relatively low threshold for radiation. So the DVH, or the dose volume analysis, dose volume histogram, allows us to really look at all of the various organs we're trying to spare and really determine, how good of a job are we doing, and at what point do we say, 3D conformal is not doing a good enough job of sparing these, and the only way to spare this and really reduce the risk of patients developing complications is to use IMRT. So it's tough. It's tough to review. It's tough to look at. You have to be a rad onc essentially to really understand and appreciate a DVH and to read it.
Great. There is another question. How, if at all, does radiation oncology, or do you work or integrate with medical oncology?
Yeah, so from an eviCore perspective, I think I think historically we've, when we think of radiation benefit managers, we've oftentimes sort of been perceived as these silo entities, and then admittedly we have been in many ways. radiation oncologists, and we do sort of our thing, and medical oncology or other disciplines kind of do their thing. But what we've been doing more recently here has been working together, because we all understand that patients are going through various journeys here, and it's important that we all align. Just like you have a multidisciplinary tumor board in the hospital or in the clinic, we actually have one as well, where we're getting all of our experts together and really discussing various different cases to ensure that the patient is getting the right treatment. And actually, oligometastatic disease is one of those that tends to be on that docket a little more often, because if a patient, as we talked about, doesn't quite meet the sort of definition or isn't really truly presenting in an oligometastatic state, then sometimes it's systemic therapy that's more appropriate, or in fact, sometimes it's even observation. And so I think it's important that, just like in the clinic, colleagues talk to each other, we're doing the same thing here to be able to really ensure that if a patient presents in a particular way, that we're making the right recommendation for that patient.
Great. I think there's time for one more quick question. Again, if there are any other questions, please submit them through the Q&A, and we can always follow up with them after the presentation. The last question here is around claim denials and getting some pushback on claim denials. Can you discuss how that is handled, or how we can handle that?
Yeah, I mean, it's almost a whole different presentation, to be quite honest. Claims is really half the battle for a lot of folks. Prior auth, I know, gets a lot of attention, and I can understand that. But claims is the other big area. I'll say that, at least I find that many times, even when a provider is doing, evidence-based therapies, the billing side is so complex that invariably there's a lot of, misbilling, unintentional misbilling. It's just complex, and so it's something that we can certainly support. But claim denials, these are challenges for providers, and I oftentimes really try to put out plug for Astro here. They on a yearly basis publish their coding resource, and so for anybody that's really dealing with claim denials on a regular basis, I think it's critically important that you understand radiation coding, and one of the best ways to do that is to get yourself a copy of the Astro coding resource. They, again, publish it every year at the beginning of the year, and they do a tremendous job in really summarizing very well all the nuances around radiation coding. It takes a lot to learn, but it's something that is it just takes time, but giving yourself the resources like that to help, certainly can go a long way. And then, certainly for our clients, eviCore is there as well with our expertise in around coding to help in any of those type of situations.
Great. We're just about up for time, and this does conclude our Q&A portion of the webinar. Just as a reminder, the webinar was recorded, so if you are interested in viewing the recording, you can locate it on the Insights page at eviCore.com. It will be posted very shortly. Please remember to register for our upcoming webinars. And thank you again, Dr. Singla, for your expert knowledge that you shared with us today, and thank you all for your attendance and your insightful questions. This concludes our webinar, and we hope you have a great rest of the day.